Okay, so we are live for a long time since we last saw each other. Please let me know your name in the chat box. This way the course can be more interactive. Please let me know your name in the chat box so we can pursue further with the course and make it interactive. Also, today we are going to discuss the musculoskeletal system and the most common mistakes one can do on the USMLE. Once again, please let me know your name in the chat box so we can have an interactive course. And this is the last time I'll remind you, as we are going to start the course. Okay. So, a 5-year-old patient comes to the medical department with a diagnosis of proximal renal tubular acidosis. His urine was found to be alkaline. Previously, he complained of lower limb pain, exacerbated towards the night. The doctors told the mother it is normal for his age. However, this pain continued without amelioration. On the radiography, there is diffuse bone sclerosis. To prevent a common complication, which treatment is the best option? Bone marrow transplant, calcium and vitamin D, biphosphonates, or EPO? Let me know your answers in the chat box to discuss them. Okay, the next clinical vignette will ask, in addition to his presentation, what is the most likely sign seen on the physical exam? A. Bowing of the legs, B. antalgic gait, C. impaired pupillary light reflex, or D. costochondral dilations. Once again, let me know the answer in the chat box. Okay. The answers are B. The bone marrow transplant is the definitive treatment for osteopetrosis. Hypocalcemia is a common complication of osteopetrosis. This is why we choose the calcium and vitamin D as an answer. Another choice was biphosphonates, which is actually the treatment for osteoporosis. And lastly, erythropoiesis is the treatment for chronic kidney disease. For the other question, the answer was C. Let's discuss a little bit the other choices. The rachitic rosary and the bowed legs are seen with rickets. An antalgic gait is seen in SCFE as well as in Legg-Calvé disease. Lastly, osteopetrosis and Paget disease can cause cranial nerve compression, leading to an impaired pupillary light reflex, which is based on the third cranial nerve on its efferent component. Are there any questions on this topic? Okay, then let's pursue further and review a little bit the osteopetrosis as a clinical entity. Its pathophysiology is a deficiency in carbonic anhydrase 2. This is the reason for having a proximal and distal renal tubular acidosis associated with it. For instance, if you have a proximal renal tubular acidosis, then we have an impaired bicarbonate reabsorption. Since there is no acidic environment for osteoclasts to work within, there is an excessive bone deposition. The clinical and lab findings for osteopetrosis are pancytopenia, as the bone marrow is replaced, cranial nerve impingement, as discussed previously, hypocalcemia, as well as hepatomegaly. The hepatomegaly is explained by extramedullary hematopoiesis. And on the X-ray, osteopetrosis presents as diffuse cortical sclerosis. Okay. The next clinical vignette focuses on a 20-year-old male. He has an incidental finding of a bony protrusion on his CT scan. This bony protrusion is located on the facial bones. His father died of colon cancer at the age of 40. What is the most likely diagnosis for his finding? A. Osteoid osteoma, B. An osteoma, C. Osteochondroma, or D. Osteoblastoma. Let me know your choice in the chat box. Okay, Let's go to the next part of the question. So actually, before going to the next part, the answer is B, an osteoma. Let's review a little bit the benign tumors of the bone. An osteochondroma presents with lateral bony projections that are covered by a cartilaginous cap. It can transform into a chondrosarcoma. It is the most frequent benign tumor, and it involves the metaphysis of the long bones. The osteoma is a tumor of the facial bones. It is frequent in young males, and it is associated with Gardner syndrome. This is why the patient's father had adenomatous polyposis, familial adenomatous polyposis. An osteoid osteoma is frequent in young males. It is a tumor of the long bones. Now, the difference between osteoblastoma and osteoid osteoma is that the pain ceases with NSAIDs for osteoid osteomas, while while osteoblastomas have a pain that does not cease with NSAIDs. Lastly, the osteoid osteoma presents on the X-ray as a bony mass with radiolucent bony core. On the other hand, the osteoblastoma presents as a tumor of the vertebrae. Also, it is more frequent in males. All the benign tumors are more frequent in males than in females. Okay, are there any questions until this point? Okay, so we have a clinical vignette that says that there is a patient of 50 years, with an erythematous knee region and pain since 2 months ago. His medical history includes atrial fibrillation, hypertension, smoking, and a sister who developed a breast tumor in her 30s. On the X-ray, the distal metaphysis of the femur presents in a sunburst pattern. The patient undergoes surgery and local radiotherapy. What is the most likely risk factor in this patient? A BP of 150/90, smoking history, atrial fibrillation, or a BRCA2 mutation? Let me know your answer in the chat box. Okay, the answer to this question is C, atrial fibrillation. Let's make a little bit of a review for osteosarcomas. This patient had an osteosarcoma. The osteosarcoma is the most common primary malignancy of the bone. On the X-ray, it presents as a sunburst pattern or a Codman triangle. It is a painful mass, and it can present as pathological fractures. The risk factors are represented by Paget disease of the bone, by radiation, by bony infarcts, as this patient probably had due to atrial fibrillation, familial retinoblastoma, and Li-Fraumeni syndrome. Do you have any questions on this topic? Okay, for a short break, consider contributing to the growth of the channel by becoming a patron. You will have the link in the description. For more USMLE related content, try to access the playlist also in the description. We have a 4-year-old female that presents with high fever for more than 2 weeks. She has never left the country. During this time, she developed a salmon-colored rash. On the physical exam, the patient has a liver that passes with 10 centimeters from the costal margin. What is the most likely finding on her serology? An ANA negative, an ANA positive, Salmonella typhi IgM or Salmonella typhi IgG? Please let me know your answer in the chat box. Next, a 7-year-old female presents with joint pain for 1 month. The pain was felt in the ankle, but it also spread to the knee joint. She also has a red eye and blurred vision since 2 weeks ago. Her mother said that it is an allergy as the spring season is upon us. What is the most likely diagnosis? Oligoarticular juvenile idiopathic arthritis, polyarticular juvenile idiopathic arthritis, psoriatic arthritis, or still disease? Let's see the answers. So the answer for the first vignette is an ANA positive test, while the answer to the second vignette is an oligoarticular GA. Okay, let's discuss a bit the differences between oligoarticular, polyarticular, and still disease. An oligoarticular juvenile idiopathic arthritis involves less than 4 joints. It typically presents with uveitis and is more common in young females. On serology, there is a negative rheumatoid factor and a positive ANA. For the polyarticular juvenile idiopathic arthritis, there are more than 5 joints involved. The ANA is positive, but there is a negative rheumatoid factor. Also, it is common for young females. Still disease has late joint involvement. It presents with a salmon-colored rash, a high fever, and hepatosplenomegaly. Okay, any questions on this topic? So leave a comment below with a topic that you find difficult. In this way, one subscriber who commented will win a one-on-one tutoring session with me on his difficult topic. Thank you for joining today, and see you in the next one.